think we should go ahead and get started. I want to welcome everyone to the Department of Medicine Grand Rounds today. Today, we are honored to have a visiting speaker, and I am going to turn it to Dr. Shanti Srinivasan, the Division Director of the Digestive Diseases Division, in order to introduce our guest today. So Shanti, if I could turn it to you.
Sure. Thank you, Dr. Armstrong. And it is my pleasure to introduce our speaker today, Dr. Prakash Gyawali. It's a great pleasure and honor for me to introduce him. I want to start by saying that during my GI fellowship at WashU, Dr. Gyawali was my mentor, and I was fortunate to shadow him and observe him how he takes care of complex GERD and IBS patients. His patients adored him, and he inspired us as fellows to pursue a lifelong career of learning to understand complex diseases. So Dr. Gyawali was one of the reasons I was interested in gastrointestinal motility disorders and continue to pursue that today. So a little bit about his background. He did his medical school and postgraduate training in Calicut Medical College in India, following which he was a senior house officer at the UK hospitals. And then he did his residency fellowship, and he was a chief resident, followed by a gastroenterology fellowship at WashU in St. Louis. And then over the years, he has risen through the ranks and now is a professor of medicine at WashU in St. Louis. He is also the fellowship program director for the Division of Gastroenterology at WashU, and also the director of the Neurogastroenterology and Motility program at WashU. In terms of his recent recognitions, he had several on his CV. So in the interest of time, I'm going to go over the most recent ones. He's very well prominent both nationally and internationally in terms of in our major gastroenterology organizations. He was recently nominated as a co-chair for the American Gastroenterology Association Future Leaders Program. He is a board member of the American Foregut Society. He also is a member of the Esophageal Disorders Rome Committee. I think we'll hear a little bit more about this today. And then many of you may know the WashU Manual, and he is has a key role in this in terms of the gastroenterology part. He's also an editor of the WashU Manual. In terms of other, editorship, he's an associate editor for several journals. I'll just name a few: Diseases of the Esophagus, Dysphagia, American Journal of Gastroenterology. And what is very amazing about his career so far, he has 260 publications on a variety of topics, many related to the esophagus, as we will hear today, and also very new and innovative methods to teach is some of it. His recent publications are on that. He has 73 book chapters to his credit and 27 invited reviews. He's currently NIH funded and has held NIH funding through his career, as well as funding from other organizations like Mentors in Medicine. It's an honor to have him today. I think you're going to enjoy his talk today on hierarchical approach to evaluation of esophageal symptoms. I would request that if you have any questions, please, you can put them in the chat, and maybe towards the end of the talk, I will read them out and ask them to Dr. Gyawali. So with that, I'd like to turn it over to him, and welcome, and thank you for being here.
Thank you very much, Shanti, and thank you for inviting me. It's a privilege and honor to be presenting Grand Rounds today. Thank you so much. I'm going to try and talk you through how a modern approach can be pursued in the evaluation of esophageal symptoms, and we'll try to make it simple by lumping these symptoms together into different groups. My disclosures are at the bottom of the screen. So the purpose of evaluating esophageal symptoms is to improve them, to treat the patients and improve them. And so we start by characterizing symptoms and then applying appropriate testing, analyze and interpret results, which allows us to choose appropriate management in order to achieve symptom improvement. And we have different classification schemes and consensus documents that help us. These are guardrails rather than directives on how to diagnose and manage these conditions. So these documents help us phenotype the esophageal disorders into different categories. But it's also important to remember that the patient may have had past investigation, past treatment. And most importantly, it's important to remember that disorders may overlap. So somebody with reflux disease can have a superimposed functional disorder. If both are not treated, the patient's not going to say their symptoms are better. So let's start with history and questionnaire. So that's the initial approach. We like to talk to the patients and figure out exactly what they have. But the issue with history is when you compare the performance characteristics of a story or a questionnaire, the performance characteristics are suboptimal when compared to objective information from testing. So this is these are the performance characteristics for GERD-related questionnaires. So GERD-Q and RDQ are reflux-related questionnaires. This is a primary care physician taking an esophageal history, and GI physicians are not much better. Now, if you gave the person a PPI for any foregut symptom without being very specific, again, performance characteristics are not very good. But if you gave the PPI for a troublesome GERD symptom, so in other words, you took a more detailed history and decided that the person has a symptom that could fall into the realm of typical GERD, the sensitivity goes up at the cost of specificity. Dysphagia, not much better. The BDQ is a questionnaire used to quantify dysphagia, and you can see that the performance characteristics of all of these are suboptimal. But so even though patient-reported symptom questionnaires may be used at the beginning, at the starting point of evaluation, questionnaires alone should not be used to diagnose specific esophageal conditions. The other point this tells you is that the one-word history is never great. So just to say somebody has dysphagia or somebody has heartburn is not going to be enough. And that's part of what the questionnaires extract. They can't really go into the individualized or the personalized history that we can get when we talk to the patients. So let's start with history and transit symptoms. So these are considered transit symptoms or consequences of transit symptoms. And transit just means something to do with movement or abnormal movement. You can see that all of these have some relationship to transit. Chest pain is there because if a patient says, I have pain while I eat, that could be a surrogate for dysphagia. So if the patient says, I have pain in the middle of the chest as I am eating, they might be indirectly telling you the food's not going through and that's why I'm hurting. So it's important to remember that element of chest pain. As you can see, you won't get that if you just have the one-word symptom. So when patients have these symptoms, we always worry that there is a sinister etiology. And indeed, if there is weight loss, there could be a sinister etiology, even though the sinister etiologies of dysphagia are limited. They're mostly cancer or some profound motor disorder. Most of the time, these symptoms are profound and they can affect the patient's life, and they're rarely just an annoyance. It's important to try and put the patient's situation into one of these buckets, because that tells you the urgency and the intensity of investigation that you need to do up front. If you think it's just an annoyance, the patient's already been investigated before, then the need for urgent repeats of these investigations may not be that high. Dysphagia or transit symptoms come in different flavors. Now, we talk about esophageal dysphagia, that's something stuck on the way from the throat to the stomach. That's esophageal dysphagia, something happening in the tubular esophagus. But dysphagia can also happen as a transfer symptom, transfer of food from the mouth into the esophagus. And the characteristic of that symptom, oropharyngeal dysphagia, is a little different from esophageal dysphagia. So oropharyngeal dysphagia can have some of these associated symptoms. It's localized in the high neck. There can be collateral damage to musculature or other nerves that control oropharyngeal functions. The patient may have drooling or nasal regurgitation. They may not be able to protect their airways, aspiration. The localization is always very high in the neck. And one other point that's useful, oropharyngeal dysphagia happens within a second of attempting to swallow, so right away. On the other hand, esophageal type dysphagia is localized to the sternal notch below and may be associated with regurgitation and chest pain. And how we investigate is different. The oropharyngeal dysphagias are investigated with video fluoroscopy, even though there is a push towards using manometry for this. Video fluoroscopy of cineesophagography is the gold standard, whereas the esophageal dysphagia, we investigate with endoscopy of barium or manometry. We'll focus more on esophageal dysphagia for this talk. So if you were to endoscope a patient, that's a normal EGJ, but these are some of the other abnormalities that you could find. You can see rings and eosinophilic esophagitis, which you can diagnose with biopsies where you see high eosinophil counts. It's now recommended that even normal looking esophagus should be biopsied for eosinophilic esophagitis if the symptom is dysphagia. You see erosive esophagitis at the bottom, which has resulted in scarring and narrowing. You see a peptic stricture, which just means acid-induced stricture, reflux-induced stricture. You can see erosions there, and cancer. So these are all some of the findings that you could see when an endoscopy is done. But it's important to remember that reflux, which is more common than any of the other etiologies as a mechanism for dysphagia, the evidence for reflux is very low, even in treatment-naive patients. So even in patients who are not on a PPI, the likelihood of finding esophagitis on endoscopy is only about 30% on no treatment. If the patient is scoped on PPI after they've been on a PPI, the likelihood of finding esophagitis is even lower. And by esophagitis, we mean one of these 4 grades of esophagitis. So you can see that the grades show increasing intensity or increasing area involved with lining damage in the esophagus, inflammation. This is all visual evidence of lining damage, LA grades A, B, C, and D. There's an issue with these grades. The lower grades can overlap with what we see in asymptomatic controls. So the grade A findings may not be conclusive for reflux because we can see them in people who are just walking around with no symptoms. And that has been seen time and time again. The higher grades are almost never seen in asymptomatic controls. Now with endoscopy, you can see other findings that could help lead the diagnosis towards, lead the investigation towards a diagnosis. You could see Barrett's esophagus, you could see a hiatus hernia, you could see a narrowing in the esophagus. You could also see disruption of the esophagogastric junction. This is looking back at the esophagogastric junction after reaching the stomach by using a maneuver called retroflexion. So the black you see at the top is actually the endoscope. You're turning the wheels back to look back. And you can see again, there's grading here, 4 different grades of how disrupted the esophagogastric junction is. So all of these findings have high specificity for a diagnosis, but low sensitivity because not many patients have these abnormalities, even when they have disease, especially reflux. And profound motor disorders like achalasia, where the sensitivity of endoscopy for picking up achalasia is only about 40%. So we do start with endoscopy when somebody has transit symptoms, and these are some of the conditions you might diagnose with an upper endoscopy. If you find these, you're done. If these disorders explain the patient's transit symptoms. If not, there are other tests we can do. A barium swallow. What's a barium great for? A barium is great for identifying subtle rings or strictures in the esophagus. You can combine a barium study with a tablet swallow, 13 millimeter barium tablet, and look and see if it gets impacted somewhere in the esophagus. If it does, that might tell you that there is some obstructive process there, either a structural obstruction like a stricture or a motor obstruction like abnormal relaxation of the lower esophageal sphincter. A barium study also gives you a roadmap for a tight stricture that cannot be traversed, like this one. This is a radiation stricture. Or this one, this is a long eosinophilic esophagitis related stricture. These will eventually need to be dilated endoscopically. And the barium gives you a road map and tells you whether the stricture is straight or twisted, or whether you need to use fluoroscopy, pass a guide wire, and pass the dilators of a guide wire. So it gives you a road map as to what to do next. Barium, great at identifying structural abnormalities. Barium, not good for diagnosing reflux, because even a normal person can have reflux of content from the stomach to the esophagus during a barium study, because the mechanism of reflux is inherent in all of us. And barium is not great at identifying esophageal motor disorders, motility disorders, other than the emptying disorders. And we'll talk about that in just a second. So there is value to combine barium with a 13 millimeter barium pill. And both tend to be abnormal in situations where you expect for empty. So when do you order barium studies? These are some of the indications: transit symptoms without a conclusive diagnosis, follow-up of people who have been treated for motor disorders, and for evaluation of anatomy issues at the EGJ, esophagogastric junction, or strictures. The performance characteristics of barium for detection of motility is very low. Now, what about manometry? Now, we in St. Louis are very proud of high-resolution manometry because it was developed here in St. Louis by my mentor, Ray Klaus. He was working on this when I came to St. Louis, so I happened to be at the right place at the right time. So there are two elements of high-resolution manometry that's different from what we used to do before high-resolution manometry. First, the number of sensors, the number of recording sites on the catheter that we place in the esophagus is very high, every centimeter. In the past, it used to be very infrequent. So you used to have 3 or 4 sensors on the catheter prior to high resolution. And the data that comes out of high resolution manometry, this is the pressure profile of a water swallow with the catheter in place. You have computer programs that assimilate this data and add in best fit data between these recording sites and assign color to amplitude levels. So you can see the color assigned here. And the reason for that color is that you can now look at the swallow profile as if you're flying over it, just like a weather map. And so this is the peristaltic signature, the image of a water swallow in the supine position. And you can see that it's visually intuitive. You can see both the sphincters as bands of pressure, brighter colors, higher pressure, blue spectrum, low pressure. So you can see both the sphincters in the same window. The operator can learn to recognize this and understand that the catheter is correctly placed. So there's real-time visualization of catheter position. And if the catheter doesn't make it through, you can immediately detect it. This is a butterfly pattern because the catheter is curled in the esophagus. Whenever the catheter curls, it means there is some obstructive process. The nurse has to manipulate the catheter to get it through the lower esophageal sphincter. This is actually a 3-dimensional assessment of peristalsis. On the x-axis, you have time. On the y-axis, you have distance along the esophagus. And the z-axis, as a function of color, you're understanding the vigor of peristalsis, the oomph, the peristaltic amplitude, by looking at the colors. So the patterns of abnormal manometry can be easily recognized. We also have metrics. We have software tools that we use to assess esophageal function. So the IRP, integrated relaxation pressure, is the residual pressure when the lower esophageal sphincter relaxes. And the lower that pressure, the more the sphincter is relaxed. So in achalasia, you'll see that the IRP is high. The DL, distal latency, is the timing of peristalsis. So you can see the nice forward slope. That is because the top part of the esophagus squeezes first and the bottom part last. And for that to happen, you need the contraction to move antegrade, and the distal latency is a measure of that. And the DCI, distal contractile integral, is a measure of the vigor of contraction. And that is done by calculating the actual amplitude, taking into consideration the length of the contracting segment, as well as the time, the duration of contraction. Now, the location of the lower esophageal sphincter can be quickly identified because we place pH probes based on that. So compared to the old conventional manometry, high-resolution manometry allows you to look at the pattern. So increased diagnostic yield for motor disorders and better inter-rater agreement. Learners favor high-resolution manometry. So high-resolution manometry is recommended over the old conventional manometry for evaluation of obstructive or transit esophageal symptoms without a mechanical cause. And these are some of the situations where a high-resolution manometry could be requested. Transit symptoms with no clear explanation on alternate testing or a suspected motor disorder. And you can see the list below of other indications from manometry. Now, how do we interpret manometry? We use those metrics that we just talked about. So if the integrated relaxation pressure tells you the sphincter is not relaxing, we look at the esophageal body. And if the peristalsis in the esophageal body is abnormal, it's failed, or there is pressurization, or the swallows are premature, you get the 3 achalasia subtypes. And these are just the images of the subtypes. You don't need to know too much more other than the fact that you can actually look at these on the screen and decide that these are abnormal. You don't really need those metrics. We use those metrics to confirm, but these are abnormal patterns. And these are some of the most profound diagnoses you can make with manometry. And these also have the best treatment available. You can destroy that sphincter, open up the sphincter, and the patient's symptom gets better in achalasia. So these are obstructive disorders. And so we try very hard to make these disorders, make these diagnoses. Even if the supine IRP value is normal, we may try to see what the IRP value, the relaxation metric, looks like when the patient's upright, or when you challenge the esophagus by giving them a rapid drink challenge. You give them more volume of liquid to drink, or you give them repetitive swallowing. That's what MRS is, multiple rapid swallows, and see if the IRP is abnormal. Why do we do that? Because obstruction is what we are trying to diagnose or rule out when we do manometry, because that's where treatment is available. So even if esophageal peristalsis looks normal, and if the IRP is abnormal, we still take the situation further and try to make sure that that pattern is not related to obstruction. Sometimes it is, sometimes it isn't, but we try to make sure that's not related to obstruction. So a lot of times when the esophagus squeezes normally, but the IRP metric is abnormal, the causes can be mechanical or idiopathic. And these are some of the mechanical causes. And only some of the idiopathic causes, even though they have all the right symptoms, only a small proportion of the idiopathic causes actually have an achalasia-like syndrome. So it's important to recognize those, because those patients improve with achalasia-like treatments, whereas the rest may be just an artifact or related to reflux. So when we have situations where the achalasia diagnosis is not fully evident in manometry, we have to do additional tests, additional studies to try and decide if we are indeed looking at a patient with obstruction. Because if they have obstruction, we can treat it. So we try to do that by looking at what happens with the bolus. If you add impedance to manometry, you can see the bolus. In this case, you can see some of the bolus goes through, rest of it stays in the esophagus. And that relationship between bolus in the esophagus versus bolus before the peristalsis can tell you if there is emptying. You can do these challenges. This is a rapid drink challenge in a normal person. A normal person should be able to handle that drink challenge without any problems. Somebody with an obstruction looks like this. There's pressurization of the esophagus. And we can use these multiple rapid swallows. This is a normal response. There is augmentation of contraction. This is an abnormal response. There is no augmentation of contraction. So these supplementary provocative maneuvers improve the diagnostic yield of motility disorders. Now, we also sometimes need to adjudicate these borderline motility findings with other tests. And one of the most useful in that context is a timed upright barium swallow. This is where you give the patient barium and then stand them up. So the image A is from a patient with achalasia. When you stand the patient with achalasia up and take an image at 5 minutes, there's no emptying. You can still see the barium in the esophagus. You treat the patient correctly, destroy their lower esophageal sphincter with a myotomy or a palm procedure, pneumatic dilation, and repeat the test. And you can see image B, successful treatment. There is no retention of barium, in contrast to another patient where treatment wasn't as successful and the image before and after looks almost exactly the same. So barium studies are very useful in bringing out emptying or looking at emptying of the esophagus. And so the test to order then is a timed upright barium. You can see the methodology there. So a standardized timed upright barium should be used when barium is performed for obstructive symptoms, especially if you're suspecting a profound motor disorder like achalasia. The newest kid in the block is FLIP, functional lumen imaging probe. This is done during sedated endoscopy. This is a catheter that has impedance rings and has a balloon around it. And the way it works is when you pass a current of known voltage into the system across those electrodes, and there is a fluid of known conductance around it, you can use Ohm's law and calculate cross-sectional area. So if you have 8 pairs of electrodes, you get 8 cross-sectional areas. If you have 16 pairs of electrodes like this one, you get a cross-sectional area that can be depicted like this. And the relationship between cross-sectional area at the narrowest point and the distending pressure gives you what's called the distensibility index, which is very low if the sphincter doesn't open, like this one. It's 1.1, less than 2. This is profoundly abnormal, in contrast to another one, another patient where the LES actually relaxes, lower esophageal sphincter relaxes. The distensibility index is 5.8, so this person does not have achalasia. This is another of those adjudicator studies. If you compare these metrics that you can calculate during FLIP, the distensibility index, the diameter of the lumen, to manometry metrics, so the IRP, this is what you get. SIRP is supine IRP, 15 is the threshold. UIRP is upright IRP, 12 is the threshold. DI is the distensibility index, diameter. You can see the performance characteristics are similar. FLIP seems to do a little better than IRP, but this tells you that these tests are complementary. So you can use a functional lumen imaging probe as an adjudicator if the manometry pattern is not consistent with the achalasia. So we try very hard, and we use these tests like barium esophagogram and FLIP to decide if what we are seeing when we have an abnormal IRP, but the esophageal body doesn't fit achalasia, to decide if that is truly a disorder of EGJ function. If it is, you can treat it like achalasia. If not, and the patient doesn't have an outflow issue, then we use the same manometry to look for other conditions. Absent contractility, premature swallows gives you distal esophageal spasm, hypercontractile or exaggerated contraction gives you hypercontractile disorder, and weak contractions gives you ineffective esophageal motility. And these are called disorders of peristalsis. In these cases, the outflow is thought to be normal. Even in these patients, even if there is no profound disorder of peristalsis and the patient has symptoms, we continue to look for obstruction. We may do meal challenges if appropriate. And if we find obstruction, these are some of the treatments that we offer. So calcium channel blockers, nitrates are temporizing measures. They don't work very well, but Botox can be injected to the lower esophageal sphincter. It can work for a temporary period of time. Sildenafil has an unclear niche. Sometimes it helps the muscle relax, but the more durable therapies are pneumatic dilation, surgical myotomy, and a per-oral endoscopic myotomy, or a POM. POM can be tailored. The length of the myotomy can be tailored, and this can be used for spastic disorders. Now, what about non-achalasia spastic motor disorders? If there is no alternative explanation for symptoms, you have to decide if the patient has a chest pain or discomfort predominant symptom pattern, in which case reflux can be a mechanism, or visceral hypersensitivity can be a mechanism. So if it is reflux, you treat with PPIs. If it's visceral hypersensitivity, antidepressants. Now, if the patient has a transit symptom, then you have to decide if the symptom can be linked to abnormal bolus movement with all these measures that we talked about. If the answer is no, again, you go down the antidepressant trial approach. Now, if the symptom is linked to disturbed bolus transit, the FLIP is abnormal, the barium is abnormal, then you can use some of these treatments that alter what the muscle looks like. So if the patient has transit symptoms, endoscopy, if that doesn't lead you anywhere, you have manometry, you can use barium and FLIP. What you're trying to do is to find these obstructive disorders and treat them. What about perceptive symptoms? Perceptive symptoms can be typical reflux, heartburn, and regurgitation, or atypical. They can be belching, cough, regurgitation, so these are all atypical. Again, these can have those same 3 buckets that we talked about, but a lot of times these perceptive symptoms are an annoyance. They can be treated with medicine. They can be profound. They're very rarely sinister. So how do we deal with them? So the approach to typical reflux symptoms is empiric PPI therapy. There's a very nice study from several years ago when about 350 patients were randomized to a symptom-based approach using GERD-Q or a test-based approach using endoscopy and pH metry to guide management, right? And at the end of 8 weeks, symptom relief was similar, but the group where symptoms were just treated empirically had a cost savings. And so this is the paradigm for typical reflux symptoms, and it works because the number needed to treat with typical esophageal reflux symptoms for a PPI response is relatively low. Now, so that's the paradigm that is pushed these days with typical reflux symptoms, even though we know everybody with heartburn doesn't have reflux. So trial of a PPI, assess it 4 to 8 weeks. If they get better, wean to the lowest dose or reduce the dose and maintain that. They have uncomplicated GERD. If they don't have response, there is a role for increasing the PPI dose. If they respond, then you go back to the other side, the left side of the algorithm. If they don't respond, that's when further testing is needed. Usually that requires some form of reflux monitoring. Hopefully endoscopy is being done at some point. The beauty of wireless pH testing is it can be done during index endoscopy. Now, there is a role for testing even in patients who remain on chronic PPI for uncomplicated GERD before you decide to leave them on long-term PPI treatment. What about atypical symptoms? The thing about atypical symptoms is there is a high cost to investigation and management if you start with empiric therapy. So these are different arms of what could happen if you started out with single day PPI, increase in 3 months to BID, and then did testing. So empiric treatment has a high cost, whereas if you do upfront testing, the positive studies lead to similar costs, but if the studies are negative, then your cost of evaluation, cost of management is going to be very low because those patients are not going to need PPI if they don't have reflux. These are the other points in the evaluation. Now, why is this true? Because the number needed to treat per PPI response is exceptionally high with these extra esophageal symptoms. And therefore, you'd have to treat a heck of a lot of people with PPI to get a few patients to respond. And for that reason, these atypical symptoms are best evaluated first and then treated. So upfront testing is preferred with atypical symptoms. So typical symptoms, PPI trial, patient improves, that's uncomplicated GERD. If the patient is not improved or has alarm symptoms, you jump back into the other side of the algorithm. You start with endoscopy. Atypical symptoms, you start out with endoscopy and then move on to manometry and pH testing. And these, again, to remind you, these are some of the things that would make the endoscopy positive, or endoscopy could potentially explain symptoms. Important to remember that achalasia may mimic reflux. So this was a study of 1,000 patients who underwent manometry prior to anti-reflux surgery. And you can see that 2.5% had an achalasia-like pattern. And another 2.5%, 3%, 4% had profound hypomotility that could impact the choice of anti-reflux procedure. But the bottom part of this slide is very important. You could be missing achalasia if a manometry is not done and somebody who says, I don't respond to PPI. Also important to remember the difference between refractory GERD and refractory heartburn. Refractory GERD implies that you've confirmed GERD. The person has GERD. There is no doubt you have done some testing, improved GERD, and their symptoms are not responding. Whereas refractory heartburn implies that symptoms may or may not be from reflux. So that's unproven GERD, whereas refractory GERD is proven GERD. And it's important to differentiate this from no GERD. And that's part of where investigation leads you. So prior GERD evidence, if the patient has had prior endoscopy with some of those findings that we talked about, that is a patient with proven GERD. If they don't have that, that's unproven GERD. So if you're going to investigate somebody with unproven GERD, the purpose of testing is to determine if GERD exists. So these patients are tested off PPI. And you can do wireless, as shown here, wireless pH monitoring, or catheter-based pH or pH impedance monitoring. We'll touch briefly on these in just a second. So this is what you would see if you did any kind of pH monitoring. These are reflux episodes, drops in pH in the distal esophagus below a threshold of 4. And each episode has a sharp drop and a stepwise return to baseline. Now, we calculate a metric known as the acid exposure time, which is the cumulative time the pH is less than 4 in the distal esophagus, and that is expressed as a percentage of the duration of the recording. And there is a physiologic threshold, which is 4%. So 4% of the time, we're all allowed to have acid in the distal esophagus. Why is this important? Now, if somebody has heartburn and negative endoscopy, but a positive pH study, their response rate to treatment with a PPI is just the same as if you saw erosive esophagitis. That's the modern definition of non-erosive reflux disease. On the other hand, if the patient just has heartburn, you have not endoscoped them, or if they have a negative endoscopy and the pH study has not been done or a pH study is negative, then your response rate is a toss-up coin, 50%. What about impedance? Well, this is an acid reflux episode like I showed you, but if you have impedance, you can actually see the impedance signature of liquid moving up the esophagus. Impedance is measure of resistance to flow of a current. So if there's liquid in the esophagus, the impedance goes down, which means the current flows easier. This is the impedance signature of a reflux episode. This is the impedance signature of a swallow. And this is the impedance signature of what's called a non-acid reflux episode. There is no pH drop, but there is content bolus moving up the esophagus. So pH impedance monitoring has a higher sensitivity for detection of reflux episodes. And because you detect more reflux episodes, the likelihood of being able to correlate that with what the patient says their symptoms are is higher. But it's important to remember that it's the acid reflux episodes that become non-acidic if you give some patient a PPI. It is possible to do a pH impedance study on PPI. But even if you did a pH impedance study, the metric from a pH impedance study that predicts symptom improvement with anti-reflux management remains an abnormal acid exposure time. And you can detect that to a higher degree if you study the patient off PPI. So acid is king in terms of managing reflux. Now, what about studies on PPI? Now, you can do studies on pH impedance studies on PPI, but it's best to reserve that for patients with what we call proven GERD. So you know they have reflux disease, you've treated them with PPIs, they say they're not getting better, and now you're trying to decide if they're not better because their reflux is not adequately controlled, or if they're not getting better because they have some other condition and the reflux is controlled. That's where these studies on PPI are most useful. Now, we evaluated this last year in a multi-center, multi-continent study. Healthy volunteers, if you do a pH impedance study on BID PPI, their reflux metrics are just minuscule, so you cannot use those as thresholds. But if you take these patients with proven GERD with either heartburn or regurgitation and look and see what predicts ongoing symptoms, one of the metrics is a high number of reflux episodes. A number of reflux episodes, more than 40, had decent sensitivity, modest specificity to predict ongoing symptoms. An acid exposure time on PPI of 0.5 had modest performance characteristics. So these by themselves didn't function very well. But if you combine this and took patients with these metrics and sent patients who were symptomatic with abnormalities in both of these to surgery, you can see that the response rate's great, especially for regurgitation. Now, if you use more stringent metrics, if you needed the acid exposure time to be above the physiologic threshold of 4, or more than 80 reflux episodes, or another metric called baseline impedance, mean nocturnal baseline impedance, which is a measure of mucosal integrity, that value was low, then the response to surgical treatment was even better. So in patients with proven GERD, doing these tests on PPI can sometimes be helpful in deciding which patients to escalate reflux management towards anti-reflux surgery when they have persistent symptoms. And so using all of these metrics together, the international community came up with what's called the Lyon consensus, where conclusive and inconclusive evidence for reflux were characterized. So this is data from endoscopy. This is data from pH testing. Acid exposure time more than 6 is conclusive evidence. 4 to 6 acid exposure time, 4 to 6% is borderline evidence. In reflux episodes, 40 to 80 is also borderline. So what do you do when it's borderline? You look for adjunctive evidence, and we'll talk about that in a second. And you saw in the last slide the evidence for no reflux, which is acid exposure time less than 4 and very low numbers of reflux episodes. So wireless pH monitoring can be performed during that index endoscopy if the patient is brought to the endoscopy suite off PPI for 7 days. It can rule in and rule out GERD, and it gives you up to 4 days of data. So it can look at day-to-day variation in acid burden. On the other hand, the problem with the wireless pH monitoring is there's only one site of pH monitoring, pH recording. So a patient drinking acidic material cannot be differentiated for somebody who has reflux. There's also the cost of endoscopy, cost of sedation, and the small chance of data loss if the probe were to fall off. Now, catheter-based monitoring, the biggest hindrance for this is that the interpretation requires expertise because the automated read is not reliable. But it has some positives. It can define the actual content of reflux. You can look at the baseline impedance and decide about longitudinal damage to the esophageal lining. You can diagnose the behavioral syndromes that are belching predominant or air movement predominant. But it's important to have good expertise in people reading these studies. And so to move a patient from unproven GERD to proven GERD, you need the information in the 3 boxes here. So endoscopic evidence, acid exposure more than 6, and if you don't meet those, some of the supportive metrics from pH or pH impedance monitoring that will sway the decision towards or away from reflux. Now, if the patient has proven GERD, if the patient has all of these and is symptomatic, then you are testing that patient to decide why symptoms are persisting. And so you test on PPI, the only test available, catheter-based pH impedance monitoring. What about manometry in the context of reflux disease? So again, you can use the IRP to diagnose achalasia. And as we talked about, up to 2.5% of what sounds like GERD not responding to PPI might have achalasia. And you could have absent contractility, which can impact how anti-reflux surgery is done. And you can have these incomplete syndromes like EGJ alpha obstruction. Some of these are achalasia variants, others are strictures, some others may be artifacts. So manometry can have some value there. Manometry also helps define the integrity of the esophageal gastric junction by looking at the pressure profile of the lower esophageal sphincter and the diaphragmatic crura. The diaphragmatic crura contract during inspiration, relax during expiration as the diaphragm moves up and down. Now, both of those should be superimposed in health. But if there is separation, that's where you have a hiatus hernia. So small hiatus hernia, larger hiatus hernia. Here, the hiatus hernia is so big that you don't see the diaphragmatic profile. The importance here is that the esophageal reflux burden starts getting higher, or you have a higher proportion of abnormal reflux burden as the patients have a hiatus hernia. So the presence of a hiatus hernia is seen more often in GERD patients compared to healthy controls and can contribute to the reflux burden. But the mere presence of a hiatus hernia does not mean the person definitively has reflux. If the patient has a hiatus hernia in the context of reflux, it might mean that repair of that hernia might improve the patient. So the adjunctive or supportive evidence you can see here from pH impedance monitoring, symptom association, high numbers of reflux episodes, and some of the other newer metrics like baseline impedance and the post-reflux clearing swallow. I didn't talk about that because that is not much in use. You can also have some endoscopic biopsy evidence or electron microscopy, not done very often. And now there is a new tool where you can look at that mucosal integrity using a balloon placed during endoscopy. Just got FDA approved. Doesn't have a clear situation where it has a good niche yet, but it's still being investigated. And on manometry, finding a hiatus hernia or weak contraction or hypotensive lower esophageal sphincter adds to that adjunctive evidence. Now, barium, like we talked about earlier, great for anatomic stuff like a hiatus hernia. You can see the hiatus hernia on manometry. The top image, barium image here is an axial hiatus hernia. The bottom one is a paraesophageal hernia. But barium is not great for reflux. This was a study from the Amsterdam group, 20 patients with reflux symptoms. 50 had reflux, 50% had reflux on the barium, the others didn't. And the gold standard with pH impedance, but none of the pH impedance metrics. So acid exposure time, the percent with pathologic acid exposure more than 6, the height of the reflux and impedance, the number of reflux episodes, none of those were different between the patients with and without reflux. And this is the performance characteristics of barium in diagnosing reflux. Dismal. So reflux seen on barium does not establish or refute reflux. Now, pH impedance and manometry can also diagnose other functional syndromes that can mimic reflux. And one of those is a belching type disorder, supragastric belching. This is supragastric belching. What does that mean? This is a behavioral disorder where the patient pulls in air or pushes air into the esophagus, the air never reaches the stomach and the patient belches it out. And this is a behavioral syndrome. The patient may do it unconsciously. These are the patients who loudly belch. You can hear them down the hall when they come and see you. The classic impedance signature of a belch of air in the esophagus is an increase in impedance. And you can see that that increase goes down the esophagus and then comes right back up without getting to the stomach. That's why it's called supragastric belching. So this is a behavioral disorder that responds to diaphragmatic breathing and other behavioral techniques, and not escalation of reflux management. Here's another behavioral disorder. This is liquid moving up the esophagus, just like what I showed you earlier on pH impedance monitoring. There is acid drops, so some gastric content is coming up, but the patient has reported that as a symptom within seconds, right away. That is very unusual for reflux symptoms. So this patient was reporting regurgitation, this is a patient with rumination. And so that is another behavioral disorder, learned behavior, where the patient learns to increase intra-abdominal pressure in time with expiration of the diaphragm is relaxed. This also can be treated with diaphragmatic breathing and behavioral techniques. So these disorders, behavioral syndromes, can overlap with true reflux. So let's put all of this together. This is our standard management. We start with lifestyle and acid manipulation. The patient doesn't get better, you need to confirm reflux before moving up the ladder, and patients with atypical symptoms have a higher need of proving reflux before doing anything else. Now, what is the anything else that you can do? Well, surgery is one of the options, fundoplication, but at tertiary centers, we also have sphincter augmentation. Gastric bypass can treat reflux. You can do radiofrequency application, which is not very well accepted as a primary approach, but maybe a niche approach for some patients. There is the esophageal incisionless fundoplication. There are some novel approaches, scarring the esophagogastric junction by doing a mucosectomy or creating inflammation at the barrier. There are also medications like baclofen, which reduce TLESR tendency and therefore can reduce regurgitation and reflux. You can use these adjunctive techniques to reduce symptoms or reduce regurgitation. Actually, diaphragmatic breathing can reduce reflux episodes as well. And there is a new class of acid suppressive agents that's coming down the pike, the PCAPs, the potassium competitive acid blockers, which actually result in more profound acid suppression compared to PPIs. So to finish up our algorithm, when you do reflux monitoring in somebody with perceptive symptoms, what you're trying to diagnose is non-erosive reflux disease. And if you don't find that, the patient may have a functional or a behavioral disorder. And like I was telling the GI division, if you are involved in this field, one of my aims in giving these talks is try to encourage our young medical students and residents to come into the field of gastroenterology, and our gastroenterology trainees to come into neurogastroenterology. Because if you are in neurogastroenterology, you get to see the world. Chicago classification for motor disorders, Lyon classification for Lyon consensus for reflux, and Rome criteria for functional disorders. You get to go, you get to see the world. We need something in Asia too, and hopefully the next iteration of one of these will be in Asia. So the take-home points from my talk start with a good history, which can direct investigation. It's useful to put patients into these buckets: transit symptoms, perceptive symptoms, combination. For transit symptoms, you can see the value of some of these tests: endoscopy, manometry, barium, flip. On the perceptive side, PPI trial, useful for typical symptoms, upfront testing, more cost-effective for atypical symptoms. And you can use the concept of unproven versus proven GERD to determine whether to perform reflux monitoring off or on PPI therapy. And finally, behavioral syndromes can be diagnosed using pH impedance monitoring and some provocative maneuvers doing high-resolution manometry, and can impact managing the patient with these disorders. With that, I'm going to finish up. Thank you very much for your attention. I'll be happy to take any questions.
So thank you, Dr. Gyawali, for an outstanding comprehensive presentation on esophageal disorders. I want to open it up for questions. Feel free to put the questions in the chat, or if you'd like to unmute yourself, that's fine also. So I'm going to give a minute for people to start.
Hey, Prakash, it's Shreya. Thank you so much for a great lecture. I actually had a clinical question for you with regards to FLIP and barium. So when I have patients with EGJ outflow obstruction, I end up ordering both a barium and a FLIP, but I've noticed that the barium is frequently not concordant with the FLIP. The FLIP usually shows the decreased DI consistent with the manometry, but my barium's, unless there's like a large hernia sac or something, I usually don't see that column of barium. I don't see the tablet passing. I'm wondering, do you think I'm just over ordering bariums and should I just go straight to FLIP, or is the FLIP, more sensitive to picking up outflow obstruction in combination with manometry?
Thank you for that question, Shreya. And this is what I discussed with Anand yesterday when I chatted with him. FLIP might be overcalling some of the LES abnormalities, because when you distend a balloon within a hollow lumen, one of the reactions is a contraction in some patients. And in symptomatic patients, that might be a sign that the person has a perceptive disorder, perceptive dysphagia. Now, barium is your absolute gold standard, isn't it? So if you give the person a solid bolus and it passes without any holdup at the esophageal gastric junction, or when you give the person liquid barium and stand them up, there is no holdup in the esophagus, they have no profound obstruction. That means that you don't really need to disrupt or destroy the lower esophageal sphincter, or doing that may not necessarily improve their symptoms. So I think you're on the right track here, because there are patients in whom FLIP may be overcalling. This is why we need a much larger healthy, normal experience with FLIP. In the end, I think you have to correlate what you see with what the patient's symptoms are and how profound they are. If they are profound, then you have another option in front of you when you run into that situation. You can do a Botox trial. You can inject botulinum toxin into the lower esophageal sphincter. That is not permanent. It's temporary. It's not going to last much longer than several months, maybe a year. And so you can tell if the patient decides that impacting the sphincter improves their symptoms, and that might give you a clue as to how to move it forwards as the next step in the management.
Thanks so much.
So other questions for Dr. Gyawali? And while we're waiting, here, we have one here. Let me just open it up. So as a primary care physician, this has been a helpful talk to better understand the risk stratification and when you refer. So this is from Dr. Marshall. It's more of a comment, I think.
Yes, I agree that, putting patients into these broader buckets, even though guidelines, I'm the first to say that you can't use guidelines for every patient. The guidelines don't apply for every patient, but sometimes, having a consistent methodology of how symptoms are evaluated can lead you to appropriate investigation, because some of the things that I presented are supported by evidence. It doesn't apply to every patient, and there are always exceptions to the rule. And then, personalizing investigation and management should be the goal. In other words, you have to adapt these guidelines, these recommendations to the individual patient.
So I have a question, Prakash. Are all PPIs created equal? And for a person for the first time starting on a PPI, what would you recommend?
So thank you for that question, Shanti. And that's an important question, because there are lots of misconceptions about PPIs. I think the best work in deciding if the PPIs are created equal is done by David Graham from Houston. And he has done some post hoc evaluation of published data and categorize PPI in terms of omeprazole equivalence. In other words, if omeprazole is the standard, how does each PPI perform, right? Our go-to for most insurance companies, pantoprazole, is weaker than omeprazole. So its bioavailability is less. The PPI with the best bioavailability, or in other words, the strongest PPI, is rabeprazole. Asofex, rabeprazole. Esomeprazole and dexlansoprazole are somewhere in between. and lansoprazole has equivalency to omeprazole. So you can use that kind of potency knowledge to decide if you want to go up the ladder, if you think the person has true reflux and is not getting good response to omeprazole or pantoprazole. So my first PPI is the one that is cheapest for the patient, because they do have a good class effect. And I usually try to find out which one is preferred for the patient's insurance, and then use that at a once a day. If I'm doing upfront, I hardly see anybody with new esophageal symptoms, but if I were, that's what I would do. Start out with once a day, first thing in the morning, 30 to 45 minutes before the first meal, and at 4 to 8 weeks increase to twice a day, second dose before supper. So just for convenience, it's either going to be omeprazole or pantoprazole based on what insurance is covered.
Thank you, Prakash. And we have a question from Dr. Patnana. When do you recommend PCPs to refer patients with GERD symptoms to GI? Do you recommend open access EGD referrals for patients with GERD, and if so, when?
So I think there are two clear situations where open access referrals could work. And one of those is the patient with very clean typical type reflux symptoms that are not getting better on PPIs that have been optimized. But you have to alert the gastroenterologist, because that index endoscopy could potentially be combined with wireless pH monitoring. And if that is being done, then the patient needs to stop their PPI for 7 days or so prior to endoscopy, right? So that you can place a wireless pH probe if you don't find conclusive evidence for reflux on endoscopy. On the typical side, the second scenario is the patient who's been on a PPI for a while, and for whatever reason wants off, or you're not sure what you are treating. You're not sure what you're treating. Those patients, again, you take them off PPI and study them off PPI. The referrals are going to be the ones who you know have GERD, previous erosive esophagitis, known Barrett's, they're having ongoing symptoms. Those patients are best seen in the office, and all the options talked through. If the patient's not a candidate for escalation to surgery, there's no point doing further testing. You're just putting the patient through unnecessary inconvenience, because it's not going to change management. But if you believe that you'd want to know why their symptoms are ongoing, and that would help decide if you were going to escalate management, those patients are best seen in the office. The atypicals, they're a mixed bag. You know, I like to study them up front. And so if I see that somebody with isolated atypical symptoms has been referred to me, I like to test them first before I see them in the office. But I will see them in the office, because I need to explain to them why I'm not enamored by leaving them on a PPI, for instance.
Thank you. And then we have a question from Dr. Kobadzi. What do you think about a special diet for GERD?
I think diets help, but diets are not the make or break for reflux disease. Weight loss may be, but diets are not the make or break. Diets are useful in reducing calorie consumption, reducing meal size, and if specific food items reliably trigger the patient's symptom, it's worthwhile avoiding those. If the patient says, every time I drink, I have a horrible night, then easy to tell them, don't drink at night. You know, if the patient says, I eat chocolate and I have heartburn, then eat less chocolate. But I try not to make too many restrictive recommendations, or too many, non-specific prescriptions for diet, because it'll make the patient miserable if you take them away from things they like. So I don't usually tell a patient to not drink coffee if coffee is not a trigger for their symptoms. But some people rely on that morning coffee to and you make them irritable if they do that. So I try not to make it restrictive, but do it in a judicious fashion, so that if there are indeed items of diet that makes their symptom worse, it may be worth targeting that. But mostly it's going to be weight loss and reducing meal size, avoiding eating within a couple hours of laying down, sleeping with the head end of the bed raised.
So thank you, Prakash. That was an outstanding presentation. Thank you everyone for attending Medicine Grand Rounds. And I think we'll close the session here. Thank you.
Thank you very much. It has been my honor and privilege to present.
Talk to you soon. See you.